Guys, we're in the middle of a pandemic and these are trying times. It's hard on our mental health, our mental state. And this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees.
COVID has affected us all, and with all the negativity surrounding it, it's often hard to find the positive. One of the blessings it has given us is the opportunity to build an avenue for creating change, starting right here in our community. Discussing topics that affect us most, such as racism in healthcare, maintaining a positive mindset, creating change, the importance of advocacy, and the many lessons we have all learned from COVID. If you or your organization are interested in speaking engagements, send a message to quadcast99@gmail.com, reach out on Facebook at Quadcast, or online at drkwadwo.ca.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Well, Guest Nation, listen, we have Zain Chagla, infectious disease specialist, joining us to talk about therapeutic options. What are interventions that we could do with the early diagnosis of COVID to allow people to not only survive, but also reduce your risk of being hospitalized? And specifically, we talk about his monoclonal antibody program, which is changing the boogie. I didn't think I would be as excited as I was doing this interview, but you'll hear it in my voice. You'll hear it in Zain's voice. It truly is boogie changing what they're doing. You know, like when you look at the overall future outlook of COVID, and you look at the fact that COVID's here to stay, we need these therapeutic options for those that are high risk. You know, the vaccines are very effective, but there's certain groups in the population that are still at risk. And so this is really exciting stuff. I hope you really enjoyed this episode. Before jumping into it, I got to tell you about Solving Wellness. You know what I'm saying? Our online virtual platform that offers online workouts, yoga sessions, cooking classes, nutrition tips, mindful meditation, stress management advice, all these things to reduce burnout within healthcare. $99 a year, $9.99 per month. First month is free. Jump on the train. All right, y'all. So without further ado, Dr. Zain Chagla. Well, Guest Nation, we have a returning guest. You know Dr. Zain Chagla. A man of no introduction is needed. How you doing, my friend?
I'm good. How are you?
Good. You know, it's amazing. We didn't pump this up at all, but we got to finally meet each other, which was great. It was good to just catch up and be real for a couple hours there. So I really appreciated the encounter, my friend.
No, I loved it. Again, a lot of our social media has done such a poor thing for us that we, or even, you know, being so remote from each other, is that done such a disservice to us.
I know.
And I think, you know, there's just something so relieving about just sitting down and having a beer with someone and just talking and being able to see them and hear them and have the body language and all those other things that we used to do. Right. So
it was so good. There's just like the intangibles, like it's, as you said, like the body language is smiling. It's a different interaction. And I had a great time. We had Suman in the mix too. And so that was great.
That was fun.
And this is where we came up with this idea actually for this podcast, if I'm not mistaken. So therapeutics, monoclonal antibodies, like we've been hearing about this throughout the pandemic and they've kind of, I don't know if it's fair to say, but they've lost momentum in terms of visibility and notoriety. So like, maybe let's just start off with like, what do we need to know? Like, how do monoclonal antibodies work? What's the data to support their impact? Why don't we start there?
Yeah, absolutely. So, I agree with you. This is something that's been weird. That's kind of, there's been this medical revolution in COVID, and vaccines have been incredible. Don't get me wrong, of the pandemic that's come out. Vaccines are number 1 to 10 on the list of impact interventions globally. But the advances in medical treatments for COVID-19, particularly early COVID-19, are really incredible. And, I tell people, if we had these drugs and these potential options back in March and April of 2020, we would be rolling them out by the dozens. There'd be health systems set up for it. But it just seems to be almost a whimper these days that, we have these options, but they're not being used. So monoclonal antibodies. So monoclonal antibodies are antibodies, so the proteins that are normally used in our blood to fight COVID-19 by sticking to the virus, by preventing it from getting into the cells. A number of companies have kind of looked at which are the highest and most robust binding antibodies and basically synthesized them up in the lab. So there's a number of products on the market. They've been available for a while, although the last 2 iterations have just come to the Canadian market relatively recently. And this isn't a novel concept in infectious diseases, right? We have monoclonal antibodies to RSV that we give little kids who are premature that are going into RSV season to prevent them from getting RSV. We use passive antibody therapy for things like prevention of varicella zoster or chickenpox in pregnant women, rabies in people that are bit by rabid animals. So they're well proven therapies to really just augment the immune response and clear out the virus as fast as possible. So there are 2 on the Canadian market, one called REGEN-CoV, which is a combination of 2 different antibodies, and another one called sotrovimab, which is a monoclonal antibody that was actually interestingly derived from a patient with SARS-CoV-1, but showed a really good binding to SARS-CoV-2, and so the company decided to roll it out. And so these have been trialed for a lot of different things. They initially got put into hospitals to see whether or not they would improve patient characteristics. They didn't do a lot, although the one big trial that finally came out, the recovery trial, which is the big one that really we base most of our inpatient therapy on, that did show in patients that didn't make their own antibodies yet. So there were patients that were, largely unvaccinated or had not been infected with COVID-19 in the past, or had been infected currently, but hadn't made enough antibodies to really be visible, that their mortality dropped when they got the Regeneron compound by about 6% absolute, but 20 to 30% relative reduction in death, which is in the same ballpark as steroids and tocilizumab and all this other stuff we throw at
number
people.
Needed to treat about 16, eh?
Which is pretty reasonable to save a life in that sense, especially in critically ill patients. But, I think, the crux and the Achilles heel of early therapy of viral infections is that it has to be given early, right? This is different than antibiotics, right? Antibiotics you can give throughout the spectrum of illness. Yeah, you give them early, people likely won't get as sick, but they're life-saving if they're given very late in the disease too. We do this all the time as part of our medical care. But viral infections are very different, and it's because of the fact that the virus has its own infective phase where it's killing cells, causing damage, replicating in high amounts. And then often what brings people to hospital is not that piece, but the uncontrolled inflammation that comes from it, right? And by the time people come to hospital, much of their virus may have actually cleared out of their system. But that damage and that immune, haywireness is what's leading to people coming through, right? So we know for infections like chickenpox, like shingles, like influenza, getting drugs, antiviral drugs into them within the first 24, 48, 72 hours, even for HIV pre-exposure prophylaxis or post-exposure prophylaxis, you have this window early to get drugs into people because it prevents that virus from replicating. Once you get too late, again, it's not the virus that's causing damage. And if you stop the virus from replicating, the damage is done. The die is cast, right? What's going to happen is going to happen. It still may help, but not at the levels that it would. So these 2 drugs were trialed in early patients. So sotrovimab 5 days after symptoms. Regencov 7 days after symptoms. In high-risk individuals, and again, these trials were largely done in the era prior to vaccines, they saw a marked reduction in hospitalization, 70 to 80% reduction of hospitalization in people that are high risk, right? These are people over the age of 50, people under the age of 50 with major problems like diabetes, high blood pressure, chronic kidney disease, chronic liver disease, COPD and lung disease, that they saw a marked reduction in these people coming to hospital. In the studies, about 1% of them that got the drug ended up in hospital, to 6 to 7% that got placebo, right? So, these are really impressive drugs. And again, they're available in Canada, they're useful in Canada. And deployed in the right populations, you can actually have fairly profound effects in terms of letting people recover at home, even if they haven't, done vaccinated, which is still an impressive and probably the highest intervention to prevent people from coming to hospital. But, it gives us another option to say, we can keep people out of hospital one way or another. And that's what we should be focused on more and more.
I don't know if people will fully understand how exciting this is, because the cascade happens when, if you land in hospital, there's so many poor outcomes that could happen. Not only death, obviously, but even if you get through your admission, you're talking about, significant morbidity, your ability to, function from, being short of breath, being weak, all these things we're trying to prevent. We want you to prevent you from walking into our doors. And that just has a paramount impact. And it's kind of I don't know if Zain, if it was just me, but I did think the concept even of intervening at a outpatient level maybe didn't get as much hype, but to me, it's such an important concept, because as I said, if you walk through our doors, you've been dealing with this just like me for the last 20 months. You've seen the nature of what happens. And what I like too is we need as many options as possible. Yes, there's always going to be unvaccinated. There's going to be people with high risk that even despite getting vaccinated are still at risk of getting critically ill with COVID. So let's think about what our options are and really personalized some therapeutics, some treatments that could prevent them from seeing myself or yourself in hospital.
Yeah, absolutely. Right. And again, this isn't novel concepts, right? We've been giving antibodies to people since we've been making antibodies for the treatment of disease. It's not a novel concept. It takes work. And I think that's been the biggest thing, right? It's not something where the drug falls down and everyone's going to have access to it. You still need to get people tested. You still need a place to actually infuse this drug. It is still a COVID patient, so you have to make sure they have precautions. They have to be able to get there. But at the same time, that yield is huge, right? Let's not, the individual patient, you can change their trajectory by 70 to 80% with a single infusion, a 2-hour appointment. But from a health system standpoint too, remember, all we've been in this for from day one is we want to make sure healthcare capacity is preserved, right? And here's a tool. Yes, vaccines are going to be the biggest tool to ensure healthcare capacity. We know in Ontario, the large number of people in our ICUs and the large number of deaths are amongst unvaccinated individuals, some vulnerable individuals on that. But at the end of the day, who cares about how people don't end up in hospital? The fact is they don't end up in hospital. They don't end up costing our system money. They don't end up taking healthcare beds. They don't help burning out staff. They don't shut down essential services like surgeries. Yeah, exactly. Right. At the end of the day, if they're not in hospital, they recover well at home, regardless of how they were, helped to that outcome. That's going to have profound effects on us. And we live in a public healthcare system, right? We should be worried about patients ending up in hospital because everyone has to pay for it. So why would we not use some of these exciting therapies, build systems for people to access them and help them, right? And then the other population, the other big population, unvaccinated populations is what we've been targeting. But the others are people that, you can give them 10 doses of vaccine. It's not going to work, right? If you're getting cytotoxic chemotherapy, your immune system's wipe, I can give you 10 doses of vaccine. You get COVID during that time, you're basically unvaccinated, right? If you're a transplant patient, you're basically unvaccinated. You're on rituximab, which is a molecule that wipes out all your B cells, which produce antibodies. You get COVID, you're unvaccinated one way or another, right? So it gives us, again, a backup for those populations that are high risk, that, got their vaccine, but we know that they still need extra protection. Again, having these systems in place really do protect them. And those patients have, again, they're big healthcare spenders. They're people that we've invested huge amounts of money into to treat their disease. So why wouldn't we invest a little bit more to keep them alive a bit longer?
Absolutely. And like, to give people a context, like I think there was like Kai put out, like, your run-of-the-mill not even ICU, your run-of-the-mill COVID patient usually runs about $20,000 per admission. So like it's not chump change. And you just to absolutely be clear on this, like, in your mind, Zain, like, what's the ideal patient? Because you mentioned some immunocompromised population, but like in terms of just hammering it out, like who's the ideal patient to receive this?
Yeah, so we're generally looking at people who are at the highest risk of hospitalization, right? It will help everyone. In the United States, it's been given to a lot of people indiscriminately, regardless. In Canada, because we have a limited supply, we've been generally trying to target it to people where it's going to intervene in hospital admissions, and so we're largely targeting unvaccinated populations. And the reason isn't because we want to discriminate vaccinated, unvaccinated. These are antibodies against the spike protein. So you get vaccinated, you make thousands of antibodies against the spike protein to different pieces of the spike protein. And we know, based on good clinical statistics, your outcome, if you're vaccinated and get a breakthrough infection, is going to be better. And in fact, 90+% reductions in hospitalization, which are better than 70 to 80%. So plus, there's no issues with access or anything like that. It's in your body, it's working, that's it. And so, those individuals who are low risk, vaccinated, are, low risk of hospitalization, we're not going to take. Even high risk of hospitalization vaccinated, outside of people that, vaccines may not work in, so transplants and people are immunocompromised, it's a little bit controversial whether or not these actually do offer any more benefit. And some studies suggesting yes, other studies suggesting no. Some studies, like recovery, even suggesting harm. And so, again, we're being very careful about fully vaccinated, relatively low risk populations. And then unvaccinated people. And again, I don't care if you're not vaccinated. We've been around, whatever's happened, you've made your decision, so be it. But we do know those people are like the original clinical trial participants, where their risk of hospitalization, if they're over 50, is 5%, over 60 getting to 10%, over 70 getting to 30%. And so those are the people we want to get in, and B, people who are under 50 who have some of the risk factors for severe outcomes: obesity, hypertension, diabetes, chronic kidney disease, liver disease. Those are the people we want to get in, as they have a not high, but it's a decent chance of ending up in hospital, and we can change those odds with a single dose.
It's amazing. And I think that's another detail too, like Zain, like single dose therapy, they only have to come in once. Actually, maybe to illustrate it, actually, two things. One, let's stop the hate on the unvaccinated treatment amongst healthcare professionals. I can't stand seeing this. It's you and I have talked about this. There's so many people that land in hospital from lifestyle choices. We want as many people vaccinated as possible, but to say we're going to treat you differently is straight up bullshit. Sorry. Second, maybe let's walk through, because you set up this program, which we were celebrating online, which I'm so proud of you for really establishing this bad boy, because it's going to, as we talked about, it's going to change lives. It's going to save lives. So walk us through the program, the clinic.
Yeah. So patients are brought in a number of different ways we try to recruit them. So they're given, at our Hamilton has one major assessment center. It's an incredibly run assessment center, but that's the vast majority of people in the city. And so we pre-screen them. And again, it's great collaboration with our digital informatics team using Epic, where, right at the clinic entry, are you vaccinated and what is your age? Boom. If you're unvaccinated over 50, you get put on a list digitally. And if your test comes back positive, we get a report on that. If you're under 50, unvaccinated, you get asked the risk factor questionnaire. Again, it's done very non-judgmentally, and we give information on why we're asking. And pre-inform patients that they may be contacted about this, and they could be considering it. So we get those reports every day. We follow up on every patient that falls on those reports, give them some information, and we have the ability, we're running it 7 days a week. So, most people can be booked same day or next day if they meet the criteria, their symptoms are less than 7 days, and they're not ill enough to be hospitalized, basically. Mm-hmm. We're also, using traditional referral models. So people who, we've tried to advertise family doctors in the community, through our assessment centers in the communities, so people can be referred in if they meet criteria. And then we partnered with all the health units and kind of said, hey, if you've identified these people, please let us know. We can help them, and all of us are on the same team here. We're a regional network. Our healthcare beds are all a resource for all of us. So, please, come in and refer them. And again, we'll do the hard work to make sure they get in and get there. So we'll contact patients, usually book them same day or next day, bring them in, consent them, and just give them some information around the process. They're hooked up to an IV, and they get a 30-minute infusion, and that's it. They sit there for about an hour, monitoring for allergic side effects. They're very rare, 1 in 10,000. We have a nice TV in the waiting room, so they're watching CP24 the whole time. And then they go home into isolation, and we'll give them a call as follow-up in about a week. And we'll give some information, education on what to monitor for, just from general COVID, what to monitor for, as we're often the only healthcare providers that are involved with some of these folks. So, how to, if you're high risk, how to check your SATs, and if you're low risk, kind of what things to look out for yourself and your family. So, most people have been in and out. They've been really, really happy with the process. They're very, very happy that we're just being compassionate and giving care to people regardless of their vaccine status, which is exactly what we should be doing in medicine. And a lot of people feel better within about a day or two.
Actually, I forgot you mentioned this. You said symptomatically, you felt like people improved relatively quick. I don't know if there's data to support that, or that's anecdotal.
Yeah, no, the clinical trial showed a 4-day improvement in symptom resolution. So about 14 days to 10 days of people who got the therapy. And, most of them were getting them around day 5 to 7. So within about 2 or 3 days of getting therapy, they were better. They tend, people with kind of the fever, myalgias, muscle aches, lethargy, fatigue, those symptoms tend to be the ones that go away, because those are really viremic symptoms. Mm-hmm. They're the high viral symptoms. When they do get into cough, congestion, that type of thing, those are more inflammatory symptoms. They tend to settle a lot slower in that sense. But that, people's energy, feeling drained, all that stuff tends to really, profoundly get better in 24 to 48 hours, which is great, because when we call them a week later, they're feeling back to normal, which is exactly what we want at the end of the day.
And in terms of, you mentioned the, risks, a 1 in 10,000 allergic reaction. Is there any other side effects to watch out for when they leave you?
Yeah, we always do ask them to monitor for the COVID, especially as some of them do come a bit borderline as they're coming in. So, just to make sure that their COVID doesn't progress, as it might be too late for some of them. Their window is kind of closed. But generally, if you look at the clinical trials, there was not much else. The serious adverse events were actually higher in the placebo than the actual drug arm in that sense, right? So across most outcomes, grade 3 or 4 serious adverse events, people are getting fever, headaches, myalgias, nausea, vomiting. But again, they all have acute COVID. And so when you look at placebo, they're at about the same frequency as that. So really, it's just the allergic thing more than anything else.
Quadcast Nation, do you guys realize how we always get a little bit excited when it's system level changing boogie flavor in your mind grapes. Like, this is what I love about this, man. Like this, like you're doing this in Hamilton. I don't, before going off on a rant, are you aware of many other places doing similar things throughout the nation? Or
yeah, so Alberta has started a program just a couple of days ago, and so you can go to the province of Alberta website. They have information there about your criteria. They're enrolling people over the age of 65 who are unvaccinated and people that have had transplants. Saskatchewan has a program through Regina and Saskatoon, and again, fairly similar criteria. In Ontario, we're the largest site running things. There is a small program in Toronto and a small program in London for kind of ad hoc doses for high risk people. But yeah, outside of that, there's really nothing else going on. So we've been taking patients, however they come here, as long as they can come here in one car ride without getting out of isolation, we'll take them in that sense.
And Zain, these are already purchased, but putting you on the spot a little bit, like, has there been like a cost effective analysis, or like, because on paper, I know these drugs can be quite expensive.
Yeah, I mean, I think they're. I don't know the exact cost. I think they're somewhere between $1,000 and $2,000 a dose. We did a bit of this work, kind of modeling out how we would run a clinic. I think we budget our clinic to be about $20,000 a month, and that's 2 nurses, pharmacy, technical support, clerical support, clinical services, and janitorial support. If you take that high number of $23,000, as you said, and a number needed to treat of about 15 to 20 to prevent a hospitalization, if you've infused 20 people or 15 people, you'd be cost neutral. Mm-hmm. And if you've infused 30 or 40 people, you'd be cost negative. With the paying for the drug, you'd have to get to that 30 to 40 number to be cost neutral in that sense. Again, those are just dispensable costs. Those don't count for surgical closures, overtime pay, all this other stuff that's indispensable, right? So this is just literally consumables of a patient as they're in hospital for COVID. Opportunity
costs, not being at work, caregiver having to be at home. Like, I know there's a financial case for this. Like, I mean, and by the way, if you guys need a crew to do the paper out of this, resource optimization network, that's our huckleberry. But listen, people, this is what I'm talking about. Changing the boogie at a system level, man. Like, if you're talking people not coming through your doors, you're intervening early. You know what I'm saying? You're with an intervention that not only makes you feel better, but also reduces your risk of being hospitalized and getting severely ill. You know what I mean? Like, this is what we're talking about. Because let me tell you, the vaccines are extremely effective. But there's going to be breakthroughs for people. There's going to be people that are, as we talked about, immunocompromised, that are elderly, that are, that don't have a robust of immune response. And if we can have these tools at our disposal to, as we said, reduce that risk of coming in, reduce the strain on the healthcare system, which was a number one priority in the first place. Mm-hmm. You know what I'm saying?
Yeah, that was it. That was the goal, right? That's what everyone wanted to do. Flatten the curve, make sure healthcare resources are saved, right?
Well, then let's go. You know what I mean? Like, it's just, I think, I don't know. Like, I just think this is something that when you know about and you learn about, you just want to see it amplified, because you know how impactful it could be for our primary goal of reducing the strain on our system. So I just commending you, my friend.
Yeah. And again, this is the beginning of it, right? This is not, early treatment. There are lots of companies that are developing early treatment options for COVID-19, right? So this is the beginning. There is a huge opportunity, and you're as much of an expert in health systems transformation and that type of thing. There's an opportunity here to create multidisciplinary clinics collaborating with assessment and testing to really ensure that patients get customized therapy for their COVID-19 such that healthcare utilization is minimized and people feel better, right?
Yeah. I got like a million ideas now, actually, that, and I'd have to think through this a little bit harder, but if your PCR, or if people had faith in the rapid antigen testing or whatever was on site, like at an assessment center, and they could within, I don't know what kind of time frame, if you say you could get your PCR test within an hour, and they could legit just go down the hall and get their infusion or get their oral antiviral, like bam, you know what I mean? Like it was just like well-oiled machine, integrated system, all on the same platform, by the way, like EMR, efficient communication to all the care team. Like there's a
lot of possibilities.
There's a lot of possibilities.
In the US, there was a paper I think I read in the New England Journal where they had a MAB team basically, where it was like literally PCRs coming off the fax. They call, they say, we're going to send a team out there and give you the infusion in your home. Mm-hmm. Don't worry, like we'll do this. You'll feel better. And like, again, like really, yes, upfront costs, but what's the downstream cost savings from it, right? I like your idea. In fact, there's a center I'm working with to get their program up and active that is looking at that model exactly, that their assessment and testing center has an area where they can cordon off to actually give infusions. Yeah. And so they have access to some of the rapid test modalities, the rapid antigens and the ID now, which is kind of a rapid molecular, that they'd be able to take, people that are epidemiologic high risk, they've had an exposure to COVID, they're symptomatic, they're over the age, get them tested immediately through that pathway, and then send them over to the end of the hall to get their infusion.
Oh man, and even the home idea too. Like I'm thinking out loud here. This is off script, people, but like if you see, because they're all often multi-generational homes, congregate living scenarios. Like if I'm going to a house and I could screen family members too, like there's potential for, I mean, and like whether you do the testing on site or what have you, but there's a potential for expanding the reach, and like not only from therapeutics, but from testing, from an engagement. Like you walk into that house and say like, yo, are you vaccinated? You're not vaccinated? We'll offer that. This is why it's important. Or you have symptoms, we can do a test for you. We'll come back and give you some monoclonals if appropriate, or which we'll talk about too, maybe one of the oral antivirals. Like yes, there's a lot of potential if we're willing to have some upfront investment and think outside the box. Because we this is one thing we're bad at in medicine. Like we got to think about future. Like where's this going to go 8 months from now? Where's it going to go a year from now? Because I think you and I could say confidently, COVID's not going anywhere, and I think we got to prepare for if plan A, plan B, plan C. But yeah, this is getting me really excited because it's a little, you get to use a little bit of creative muscle here, but I think that it would benefit a lot of people.
Yeah, absolutely. And the possibilities are endless, right? You just have to have the expansion, if you look 30, 40 years ago, what oncology was, right? And I take this as an aside, giving chemo as an outpatient in a chemo center, would be unheard of, right? Mm-hmm. You would admit patients for their cancer, you give them horrible chemotherapy. They would stay in hospital for their entire course. Well, that system's transformed, right? Like, now the standard of care is big outpatient cancer centers, and rarely do patients need admission unless they have complications or their bone marrow transplant, something like that. It's doable, right? And to say that, obviously cancer is a major disease in our society, that is a huge burden, but so is COVID. It will be, and the way we're dealing with it obviously is changed the way every single person has lived. So why can't we use that creativity, right? Yes, It took time to develop, but again, positioning therapy as an outpatient, reducing admissions, giving services as an outpatient isn't unheard of, right? And in fact, again, there are a lot of healthcare systems that have transformed into that.
Mm-hmm. 100%. You think outside the box, be ahead of the curve, my friend. Couple things, because I know you got a conference that you got to hit up. So one thing I wanted to ask was the other, like oral antivirals. I keep wanting to say antiretrovirals, but
one is kind of.
Oh, is that right?
Well, it's an HIV. Yeah.
Yeah. So tell me about what we know about it's Merck, and what's the other one? Pfizer?
Pfizer,
Yeah.
So,
what do we know so far?
So Merck has a drug that's an RNA polymerase inhibitor, and in simple terms, is a molecule that when it goes into the cell mimics what happens as a nucleotide or a piece of our genome. Basically, it doesn't integrate into the host genome, but it integrates into the virus genome, and basically, as it integrates, it stops the virus from replicating and ends it. And we actually have a lot of drugs that we use that actually have this mechanism of activity. Again, the drugs we use for shingles, for example, Valtrex and acyclovir, essentially do the same thing to that virus. They kind of hijack themselves into replication. They don't integrate in the human genome, they integrate in the viral genome. So impressive 50% reduction in hospitalization amongst their clinical trials. We're still waiting for the full publication. And by the time the interim review was done, there was about 600 extra people that were enrolled. So kind of want to see those results to see if they mimic that 50% reduction. But, again, oral, cheap, available, 5 days of therapy, needs to start within 5 days of symptom onset. And again, that's that Achilles heel. You need to get drugs into people early into their disease. Otherwise, they may not work as well as you would like. Mm-hmm. The Pfizer drug is a protease inhibitor, and this is a class of drugs that we actually use for HIV. In fact, it's two drugs combined. And protease inhibitors, as the virus kind of replicates, it makes big proteins that get chopped up into little proteins that make the virus. And so all this does is break down the machinery that chops up the virus. So they're stuck as these big chains of proteins that can't be cut up, folded together, and make a new virus. And essentially, virus replication stops. These are used for HIV as one of the major drugs. They're not used as much because they had some side effects for HIV in long-term use. And it's actually boosted with an HIV drug called ritonavir, which is also a protease inhibitor, but also using a drug pharmacokinetics, so just kind of boost the level of the other drug in someone's system too. So it kind of has a 2-in-1 action. Great drugs. Within 3 days of symptom onset, if used, 89% reduction in hospitalization. If used within 5 days, about 70 to 80% reduction in hospitalization. So, again, huge potentials here, right? These are now even that model of like having to hook someone up to an IV, you bring them in, it changes. You could do this from home. You could deliver this to people. You could give these to high-risk individuals. You could have this on spec for them. You could stockpile these drugs, right? But there is still a need for health systems transformation to use these. Mm-hmm. Again, getting patients tested, making sure patients know that they, and I think one of the things that's lost in all of this is, testing is not just a public health behavior anymore, right? It's not getting tested so that you can isolate and protect other people and start contact tracing. There's an additional benefit here. You can change your personal risk of having complications of COVID-19 by getting tested early. Mm-hmm. And so, that needs to be translated across all populations, vaccinated, unvaccinated. If you get tested early, you may have access to customized therapies in the next few months. And the earlier you get tested, the better your outcomes may be to get those therapies. So there's that, getting people tested both from a behavioral and access standpoint. There's the getting people to analyze those tests and say, these are people that need therapeutic options. There's the ability to deliver those therapeutic options and then monitor patients afterwards, right? And again, that's not going to happen like that. That's not going to happen when these drugs get approved. That work needs to happen now with some of the stuff that we've been doing, and again, building these systems for health transformation to, deal with outpatient and early treatment of COVID-19. So, people I think are waiting for the oral drugs and hesitant around the monoclonals because they're an intravenous and they require inpatient or kind of clinic utilization. But you're not going to get to be able to use those outpatient, oral drugs very well if you haven't set up the process in place to be able to get people tested, get people contacted, counsel them, and give them drug within 5 days. They're going to be as useless as anything else if you're not building those systems now.
And not only, so totally agree the need to be able to have those systems now and plan like proactively, but it's also another important message I think is like a lot of people, especially if they're not vaccinated, they fear getting tested, right? Because of the stigma and all the shit that gets associated with that. But if you know, at the end of the day, you'd be able to be treated with something that could reduce your risk. That changes the landscape, and for a lot of people. Like I think that's another kind of I don't know if it's communication, messaging, or what have you, to really think about, because once again, this is what we're trying to do to prevent you from seeing us in hospital.
Yeah, absolutely. It's a huge re-education, right? Like a patient that tests positive on their way to the ICU is a failure to me, right? Like it's a failure that we could have intervened early, because that person didn't go to the ICU day 1 of their symptoms. They went day 7, day 8, day 10 of their symptoms to the ICU. But if they could have gotten tested early, and again, people have hesitations, right? They don't want to be identified by public health. They don't want to be put into isolation. They don't want to be stigmatized to say they weren't vaccinated and now they're in trouble. But at the same time, we need to change that messaging, right? Getting tested is not a public health behavior. Yes, it helps with our public health campaign, but now the primary incentive to get tested, especially in patients that are at higher risk, is to be identified for therapeutic options. And again, as long as we can intervene, keep people out of hospital, let them recover at home. We've done a service to society and keeping everyone safe and keeping everything open in that sense.
You get my creative juices going here. Actually, I think what you just said actually gave me a little bit of jump in my step. It is a failure if seeing a COVID patient land in ICU. We need to actually register that. We need to really think about really let it sink in when we have obviously vaccines, but other therapeutics where we could be intervening early to prevent it from happening. And if we have that kind of mindset moving forward, this is a thing that will help mobilize. That's the message. This is help mobilize some of these creative solutions. And I'm also just thinking out loud, once again, off script. It'd be nice to really have that, because I don't know how easy it's going to be to change the narrative of the what's the word I'm looking for? The shaming from getting a positive test and all that kind of stuff. I don't know if that's easy to address, but it got me thinking more about testing away from test center. I know it's not perfect, but if there was a way to really be able for people to do it at home effectively, maybe that's a workaround, but I don't know. That's just speaking out loud.
We have experience, right? As ID physicians, we see HIV all the time. Similar paradigm in testing, right? Yes, we have. Now we're in an era, we have huge preventative options for HIV outside of condoms. Condoms work, but they're not perfect in that sense. And some people, again, behavioral issues come in mind. But we have pre-exposure prophylaxis for HIV, meaning that if we give patients HIV medications who are at high risk of getting HIV infection before they have their high risk encounter, that it markedly reduced the risk. It almost makes it zero. In someone that's diligent in pre-exposure prophylaxis to HIV, there have been case reports of people breaking through, but it is incredibly effective in that sense. And so again, we identify patients, we make sure they get tested. We identify patients that are high risk, and we offer them HIV pre-exposure prophylaxis. We still don't destigmatize getting tested for HIV, even if you weren't able to access these therapies, and we treat patients appropriately. But again, we've changed the way it's tested. There's hassle-free clinics, there's anonymous testing clinics, there's rapid tests on site for HIV in some sexual health clinics. And so, there's been lots of work in that domain to change the behaviors around testing to make it positive health promoting behavior as compared to a negative promoting behavior where people are shamed. Lots of those lessons could be taken over to COVID, especially as we're trying to identify patients. Yeah, you may have the traditional testing route, but can you create other testing routes where people are given an anonymous number and name, and that's it, right? Right now, maybe it's a little bit dicey, but down the road, it's not unreasonable to start thinking about that, so that, you might get the people out there that, you might not identify them for public health, so be it. But if you didn't create those processes, you probably wouldn't identify them anyways, right? At least we can intervene on those people in that sense.
Amazing. Last question while I have you. It's a big one though. What big picture, like taking a bird's eye view of our situation in COVID. It's Remembrance Day 2021. In terms of where we're in general going over the next, whether you choose next few months, we got boosters coming. We got 5 to 11-year-olds being offered vaccines. There's some, today or yesterday on the news, science table talking about, like maybe this is a time that we should be a little bit more careful. Where are we going in your mind, Dr. Chagla?
It's a big question. We're in a bit of a transition period, right? And again, just put it in perspective, right? November 9th or November 10th, 2020 was that Pfizer first press release, right? Yeah. Where it was literally, we have a vaccine that may, significantly reduce infections and significantly reduce people's chance of getting sick. It's a year later. 85% of the Ontario population has now been fully vaccinated against COVID-19. So we have to be very thankful of where we are right now, that, the vast majority of people, that 85% out there are not going to suffer the complications of COVID-19. They may have a breakthrough case. They probably have 70, 80% protection now from the vaccine, which is still pretty damn good. And they're 90 to 95% protected against serious disease. And, the proof is in the pudding. Of the people in Ontario, 50 or younger, amongst the millions and millions of people vaccinated in that age group, there have been 5 people that have ended up in ICU and 6 or 7 deaths. And I can tell you, of those people, a good number probably have immune issues that vaccine
Absolutely.
Didn't work, right? Yeah. Like it's not just a healthy person off the street that died. The proof is in the pudding that vaccinated people are going to be at much lower risk of complications of COVID-19 going into the year. And even in Israel, where they've done this booster campaign, and you look at the 2 versus 3 dose data, the rate of severe disease in pretty much all age groups under the age of 50 is pretty much 0 in 2 versus 3 doses. So, again, there is that, as people say, this uncoupling or decoupling of cases, there are cases that are not going to count towards healthcare utilization as they did before. Mm-hmm. That's good. And I think a lot of people have lost that perspective, especially with booster campaigns. People think the vaccine is useless. It's not useless. Yes, there may be a little bit of less efficacy towards mild disease, to getting a cold in the community, but that efficacy towards ending up in hospital outside of the older age groups, which you are boosting and is probably a good idea, is pretty well preserved for most populations. And so, number one, I think we're probably going to see, unfortunately, a winter where the virus is going to find itself into unvaccinated populations. And unfortunately, if we don't roll out therapeutic options, those unvaccinated populations are going to end up, some of them having healthcare utilization and putting pressure on the system. Mm-hmm. Is it going to be enough to bankrupt the system as we've done before? Maybe not. I think Ontario has a lot of resources. We're well ahead of the curve in terms of vaccines as compared to places like Alberta and Saskatchewan over the summer that dealt with their waves a bit, at lower rates of vaccine. Is it enough to make people uncomfortable? Yeah, for sure. There's a lot of unvaccinated people out there. We're seeing now a lot of transmission in the community, especially, places like Sudbury, Elmer, Ontario, places that traditionally didn't get hit, that are now getting COVID and Delta transmitting into their communities. So, I think, again, this process of living with COVID-19, having healthcare utilization as low as possible, but still recognizing that we'll have to keep some available for these patients. Again, recognizing early treatment options is going to be important. But I think, again, we're at a very different point in this pandemic, right? Again, the risk profile has changed for a good chunk of that 85% of the population that's fully vaccinated, where even the risk of breakthrough infection is going to be different. And so, as people are talking about ways to reduce transmission significantly, it's going to be hard to use measures that are global to reduce the risk of healthcare utilization amongst a small group, right?
Amen.
It's going to be hard, right?
This is something that is it's a level of nuance that you're not hearing about either. I tried to bust that out on the news a little bit. Like at this point, we should be adding a little bit more precision, asking ourselves, hey, where are these communities that are having the higher level of transmission, and what can we do to intervene? This is where I think, like, if public health wants to put up their muscles, a group of people that offer therapeutics, that offer vaccines, all these kind of tools at their disposal to like be ahead of the curve again. This is the time now.
Yeah, absolutely. Right. And again, we have these tools, right? You know, if the goal is, even if we see these surges, to make sure that they stay in the community, this is why we're talking. We need to use these tools now. They may not be perfect. We still have to get people tested and make sure that their health units are equipped to do testing. But at the end of the day, you know, again, there may be a little bit of room for some public health measures. They may get you 2 or 5% reductions in transmission. But what's going to drive transmission is going to be, and what's going to drive healthcare utilization is this group. You know, it's fine. You know, we just need to create, you know, opportunities for these people to get tested early, to get treated early, to mitigate spread in those populations as much as possible with contact tracing, to be non-judgmental about testing, because again, this us versus them mentality of people vaccinated versus unvaccinated is pushing unvaccinated people to not get tested until they end up in ICU. Mm-hmm. And so, you know, again, you know, these making more harsher and more tough language towards these individuals will have downstream effects there, right? And again, the last thing we need is people not being honest with contact tracing, not being, you know, getting tested too late before we could intervene. And again, that might be our pressure more than anything else going into the winter season.
Yo, man, now I think about it, we should be linking you up with like cats in Scarberia, Peel. I'm telling you, Zain, I haven't had an episode where I've had so many ideas busting out. I know, I'm sure this is not an original idea, but like,
no. Yeah, we were actually we're working with the assessment center in Mississauga, so they're going to be helping us with providing therapy to patients. So we've actually given a few people in Mississauga some treatment already. So again, we're anyone who wants to come here, and we're going to, you know, help and offer this as a provincial resource to at least this region in that sense. So yeah. You know, this is it. Like, that was the reason we stared this, right? We wanted to just be a resource. Yeah. Yo,
we're gonna, and this is the other thing, because you've done a couple of news spots on it, eh? Like,
yep. Yeah.
Did you do any? Did CBC National pick that up, or has it been mostly regional?
Regional stuff, I think. There's a couple of national news sources, but yeah, not a ton.
Okay, we'll make a push, man. We'll make a push. We'll this episode will come out on Tuesday, and then we'll just give it to all our media sources, because like I mean, people, you know, on the show, I don't say this much, but like, this is a needle mover, man. Like, when you sit down and think about it, it truly is a needle mover. I'm not sure if that's an expression totally, but like, like when you have that option and you have that tools, like, we need to just increase awareness and get that ball rolling. Like, I was thinking, even in Ottawa, I don't know who you've connected much with in Ottawa. I haven't heard much of that, but mind you, COVID's a bit different baby here. Like, we're really like,
sheltered.
Yeah, we're really sheltered. A lot of people working from home, less essential workers and so forth, and like one of the highest vaccination rates globally, actually. Listen, I know you're on the clock, buddy, man. Oh, I knew when you said we got to do this, I was like, yeah, of course we got to do it. But this one got me going, my friend. This is great. Like, I knew you're doing something special, but I didn't realize it was this special when you say the numbers. So, Zain, thanks again for doing your part to contribute and squeezing us in with such a busy schedule. But thanks so much.
No worries. All the best. Take care.
Take care. Bam! Tell me that wasn't delicious, people. Zain was just throwing down knowledge left, right, and center. And frankly, he was inspiring. Leave any comments at quadcast99@gmail.com. Follow us on Instagram, YouTube, Twitter, Facebook at Quadcast. Leave that 5-star rating. Tell me after this show you didn't want to leave a 5-star rating. Leave it on this show specifically, people, because this is a boogie changer, man. This is going to potentially change the landscape of pandemics and moving forward. I'm so jazzed up about this one. And guys, Thanks for listening. Thanks for the support. We love you. We'll connect again real soon. Peace.